evening, everyone. My name is Dr. Marlene Saunders, and I'm very pleased to welcome you to tonight's session titled Promoting Mental Wellness and Resilience in Our Sussex Communities. Those of you who joined us last week know that our focus was on adults. This evening, we will be focusing on promoting mental health wellness and resilience in children. We know that children come to mental health clinicians and to schools with many mental health challenges created by trauma, unsatisfactory or troublesome relationship with peers, as well as sadness. But we also know that these risk factors do not necessarily predict negative outcomes because of protective factors. Our very competent and skillful mental health providers this evening, along with the state's strongest advocate for mental health services in Sussex County and the state of Delaware, will talk to us about how they help children overcome the odds despite the mental health challenges they face. We invite you to ask questions in both the chat and the Q&A. Now, it is my pleasure to introduce you to, or to turn the program over to my friend, who is a retired educator in Sussex County, Ms. Sherelle Clark.
Thank you, Dr. Saunders, for setting the stage for this evening's panel discussion. Our first panelist is April Albury Harmon. April is a licensed master social worker who has provided mental health services to children and their families for the past 13 years. Currently, as a school-based family crisis therapist, she works with the state of Delaware Department of Service for Children, Youth, and their Families, where she continues to provide social, emotional, and behavioral support for elementary age students. As an independent contractor for Healing Pathways Counseling Services located in Seaford, Delaware, Ms. Albury Harmon provides outpatient counseling to teens and adults. We are so happy to have you this evening. Welcome.
Thank you so much, Sherelle, and it's a pleasure being with everyone this evening. I want to start off by just talking about my role as a family crisis therapist in the Laurel School District. I've been with the department for about 12 years now, and I provide services to the students of Laurel Elementary School. There, as a family crisis therapist, I work very closely with teachers, administration, and families of the students to be able to provide services for them when there are concerns regarding to mental health or social, emotional concerns within the classroom. The goal of our program, K-5 Early Intervention, is to intervene with students early so that we can help prevent long-term consequences of unresolved behavior issues and things. So I work very closely with the students, providing social skills, providing outpatient resources and referrals when necessary, because there are students who sometimes we find as we, provide assessments and things that they do benefit or would need outpatient services, mental health services, in addition to working with the school psychologists to be able to kind of coordinate and to, again, rule out certain concerns that might be adding to the child's behavior. Our program is unique in the fact that we work very closely with the parents, building a strong relationship with the parent, making them comfortable with coming into the school, and just being able to kind of provide education to the parent when there are behavior concerns in the school and outside in the home, to be able to give them skills to help eliminate those behaviors, and to also guide them and be with them when they're making doctor's appointments, when they're scheduling testing within the school, just kind of being a liaison and an advocate for that family and that child. The biggest thing in our early intervention program that is important is a lot of our kids have a lot of risk factors that are already kind of hanging around. A lot of our students experience homelessness, where a lot of families are doubled up within homes, living with other relatives. A lot of times there's poverty. We experience family history of mental health as well as risk factors towards our children, in addition to alcohol, drug abuse at times. A lot of our students may even experience low self-esteem. A lot of our families are in today's time being raised by their grandparents. Some are within single homes, whether it be raised by just their mother, and in some instances, students are being raised by just their father. So then that's when we can come in and help again provide the service of supporting the parent, um, skill building, trying to help improve self-esteem, and we're there in the classrooms kind of cheerleaders for the student and motivating them and just working with them independently to kind of help them build that confidence so they can do well academically. And we also work really hard to break down those barriers and risk factors on the outside so that they can come to school and focus and be healthy and have a successful school year. So, I look forward to answering any questions this evening. I hope I covered a few things of what we do. We do a whole lot, and I look forward to answering any questions that you may have. Thank you.
Thank you, April. Thank you for how you help students and parents in the school each day. Next, we will hear from Norwood Coleman Jr., a licensed clinical social worker with over 20 years of experience with working with children to overcome serious mental health challenges, including trauma. He is recognized as a trauma expert in Delaware by the International Society of Trauma Stress Study. Mr. Coleman is a strong proponent of the multicultural perspective to practice, including the integration of Afrocentric approach to social work practice with children. His positions have included clinical director of the Wilmington Child Development Community Policing Program. Currently, he is a clinical director, clinical supervisor, and a psychotherapist at the Life Health Center Incorporated. Thank you again, Norwood, for joining us. We look forward to hearing more about how you help our youth.
Hey, thank you very much, Rod, and thank you, everyone that has all come out tonight. So, yes, I'm Norwood Coleman, and I am the clinical director of the Life Health Center. And at the Life Health Center, I'd like to begin on describing what we do through understanding our mission. And our mission is to develop wellness for individuals, families, and communities. And we include the definition of wellness in our mission, as wellness is the conscious, self-directed, evolving process of achieving full potential. And we achieve this through integrating culturally competent mental health, physical health, and social health care services, and promoting positive self, interpersonal, and community relationships. And I like to read that mission on a daily basis. And our community of providers and support staff, we also review that on a daily basis. I think it's critical and important for us to do that as providers in this care that we, in the specialized care that we provide, in part because we all have, as I was having a discussion earlier today, we all have put tremendous effort and energy into our degrees, time and energy. And we spend a lot of time working with diagnoses, working with treatment. But the diagnosis and the treatment is never who we're really working with. We're only working with our fellow human being. And when our services don't put the human being first and that individual goal of wellness first, then we've not quite hit our mark. So I'd like to preface my introduction and my talk with that, is that wellness is truly what the goal is of healthcare, mental health care, and all of our variety of services. At the Life Health Center, one of the largest portions of our organization, and it's grown really due to the reception that it's had in the community. That largest section is our elementary school-based wellness. for those of you who are familiar with school-based wellness, most of them take place in high schools. We felt that it was important to look at the preventative uh, and access opportunities that wellness centers have. And we thought to ourselves, hey, well, wouldn't that be wonderful to introduce wellness and prevention and access to healthcare, as well as build the language skills and discussions around that at the elementary school level with kindergartners through fifth grade. So we currently are in the Colonial School District, and we have uh, uh, 5 wellness centers. Those wellness centers are in those 5 elementary schools: Cary Downey, Wilmington Manor, Pleasantville, Eisenberg, and a few others. And as well at the Eisenberg Center, which is our primary hub, we have that is where our medical center is unit. So we have a fully um, stocked medical center that is staffed by a medical team along with our mental health team, which provides things like vaccination, uh, um, treatment, and diagnosis in the case that a child has, goes to the school nurse and perhaps may not be able to get to their doctor after the nurse believes that they may have strep throat or something like that. The nurse is able to provide those additional services. So it functions as a fully functional clinic in the school for elementary school students. One of the biggest pieces that I'm very proud of is the work that we do in prevention. Uh, One of the things I found as a trauma therapist and a social worker is that much of the time that I spend with clients in treatment often is time spent teaching the language of how they feel. Uh, Many people come to uh, the therapeutic setting and they don't know how to describe uh, their feelings. So an example of that is a person says, "I'm depressed," but they don't understand that depression in and of itself is a cluster of feelings. I have difficulty. Um, I don't have the energy to. I don't feel energized. I withdraw from the people or things that I used to enjoy, and et cetera. And we spend a lot of time in therapy just teaching those basic skills, teaching people how to use their feeling language. And school-based wellness, one of our key prevention pieces and working with children is giving them that language, giving them an understanding that we are not a mind that is disconnected from a body and that the two occasionally meet, but that we're a mind body and that they work together and that we're a brain body, and helping kids to understand their how their bodies work. A big piece of that is that we use curriculum. We often spend time talking about social emotional learning, helping kids and to enhance their social emotional learning, which is something that is really wonderful, uh, uh, particularly in Delaware and around the country, is that schools are talking about it. And so it really works beautifully in that connection with schools. We have a wonderful way of not just working alongside of teachers, but having a common language with teachers, having a common language with family crisis therapists such as April, having common language with the students, with their parents, with the principal, and really helping to transform a climate around children where those seeds can really grow. When we talk about one of the pieces that this uh, program really points to is resilience and protective factors. And one of the things I think about with protective factors, those factors that um, those characteristics that people have that help them to resist not resist, the negative impacts of trauma and that sort of thing, can also be nurtured. And they're nurtured through the community and the environment. One of the, when we think about protective factors, those protective factors focus on not only on the individual, but they also focus on the family, and they focus on the community and the school. And so creating that integrative space where mental health, physical health, and education are all working seamlessly together uh, as a goal, creates a space where children really are able to grow. I think one of the things I often think about with mental health, and I'll close with this, is that mental health is a goal that we all want it. We often confuse mental illness with mental health. Mental illness is a reality, just like physical illness is a reality. We've all seen the impact of physical illness in small ways or large ways. It is the capacity to cope with it, the capacity to have a community around you that is able to lift, hold your hand, walk with you, and carry you after the initial wound that is really a part of the healing process. It's where the healing process begins. And one of the, I think it's so critical that when we think about those who, those children that we want to cultivate wellness in, is that we think about those who also care for them, that the wellness really begins with them. And so creating social emotional spaces, social emotional learning spaces, which is a big piece of what we do, helping people to embrace wellness and learn the skills that come along with coping with life challenges is a big piece of our goal. It's a big piece of, I think, all of our colleagues' goals. And I think it's something that as we continue this conversation, that I hope to hear more, that I hope to be inspired by others as they share their services. So thank you.
Thank you, Norwood, for clarifying your position and how you help our youth daily. I might add your shirt, if you could just lean back a little, because that is really a nice shirt that everyone should get a chance to see. Thank you so much. So next is Rosie Crosby, the Chief Strategy Officer for Jewish Family Services of Delaware, where she and her team are responsible for all aspects of business development, community relations, fundraising, marketing, communications, and advocacy. Prior to joining JFS, Ms. Crosby worked with Easter Seals Delaware and Maryland Eastern Shore, Gordenzia, and Social Venture Partners. In addition to her professional and volunteer roles, Ms. Crosby teaches a Fundamentals of Fundraising course at Johns Hopkins University. Thank you, Rosie, for being with us this evening. Fundamentals of Fundraising? That sounds very interesting.
Thank you very much for having me. I feel honored to be speaking alongside such a distinguished panel, and a bit intimidated following Mr. Coleman, Dr. Coleman. Regardless, what I want to talk to you tonight about is three things. One is attitude, one is accessibility, and the other is capacity. What do I mean by attitude? Something that's very, very important and is in this space and that we're doing as a community is dispelling the myth that and stigma around mental health. And I think Norwood spoke eloquently about the difference between mental illness and mental health. If one thing COVID showed us is that we're all vulnerable, we're all in this together, and we all need to lift each other and rise each other together. So that's my first point about attitude. The second is about accessibility. And that's what makes the importance of school-based counselors, family crisis therapists, nonprofits like Jewish Family Services, which is a medium-sized nonprofit, as well as smaller and larger nonprofits, accessibility. We need to make sure that anyone and everyone who needs help is able to get it and isn't dependent on the insurance that they have or the money that they may or may not have in their pocket. And then the last is capacity. There are not enough professionals in the pipeline or working to be able to support the need. And I just want to refer to a few statistics. According to a report on children by the CDC, mental health related emergency department visits for ages 5 to 11 have gone up 24%, and ages 12 to 17 have gone up 31% over 2019. In my opinion, that's a crisis. The rate of mental health providers has not grown at a corresponding rate. According to the county health rankings in Delaware, Delaware has one mental health provider per 350 persons. The US ratio is 1 in 270. And finally, according to the Kaiser Family Fund's mental health shortages, oh my goodness, our areas report, it's a long name, but it basically is underscoring the shortage of professionals. Delaware is only meeting 19% of the state's need. And lastly, our very own Dr. Tam of BB recently stated that there's a dangerous shortage of mental health providers. To us and to JFS and to all of us on this call, we feel it every day and we know that it's to be true. Waiting lists are growing and the need is growing. JFS is a $4.5 million medium-sized nonprofit. We have 35 providers at various levels, master's levels, licensed clinical social workers, psychologists, psychiatrists, and yes, we have interns because we need interns. We need to be able to help. About 35% of the work that we do is with children. In Sussex County, we opened about five and a half years ago. The need for services continues to grow. We're in schools, in the office, and in the community, and there's not enough of us to go around. So my request and plea and solution lies in working together. JFS, along with several other organizations, have started a consortium who's going to find ways to bring additional resources to Delaware, to Sussex County through internships, fellowships, and placements in organizations so we can grow the bench, as we say. To us, these are the primary priorities in our state, particularly in Sussex County. If you layer on top of that the increases in the increase, I can refer to additional statistics, the need for bilingual therapists. Our ratio of therapists for bilingual in Sussex County is 1 in 12,000. That is a crisis. And we need to find a way to find Creole and Spanish speaking therapists to not only work, but to stay in our county. With that, I look forward to answering any questions and being able to outline how we see that happening. My Fundamentals of Fundraising course that I teach at Johns Hopkins is very, very helpful because we know without the funds directed at some of these initiatives that no matter how hard we work, we cannot duplicate ourselves. We need to find others to help support the community's needs. Thank you.
Thank you, Rosie. Attitude, accessibility, and capacity, and the outstanding need to serve our children. Thank you again. Time will not permit me to share all that the Honorable Lieutenant Governor Bethany Hall Long does to protect and serve the citizens of Delaware. What is particularly relevant for this webinar is that the Lieutenant Governor chairs the Behavioral Health Consortium and body of individuals which they're comprised of the community advocates, law enforcement, healthcare professionals, and state leaders that all assess and outline an integrated action plan to address prevention, treatment, and recovery for mental health, substance use, and co-occurring disorders. I would like to also add that the Lieutenant Governor and I are high school classmates, graduating from Indian River High School in 1981.
Woohoo, you outed us.
Welcome again, Lieutenant Governor. You knew me as Sherelle Johnson then, it's Sherelle Clark now. Welcome this evening.
I love it. I love it being with my teammate and friend and colleague. I love it, Terrell, and every minute. And I love it when I get to be in Sussex with friends and family. And I am humbled to follow behind, Rosie and Norwood. And last week when we had the incredible opportunity when I was with, and I saw her earlier, Gail and Erica and Natasha, what a great forum. I'm not going to repeat everything we went over last week, but highlight a couple items for those who perhaps are new to the journey or thinking about how this can fit within the needs for our youth and their families. And as I saw participants, Jackie and others who are social workers in the front line in our schools with our children, thank you all so much. And again, I'm just going to give a high level overview, and hopefully when we delve into some of those rich questions and answers, I know we had some last week together. That was really the fun part. And with children, I hope that those of you who haven't had a chance will visit our behavioral health consortium, because a significant portion of our work, and I'll do a little commercial as a university professor, I always have to have my show and tell. If you do visit our web link, Behavioral Health Consortium, and Janae Tate is with me this evening online. If you have questions, she maybe will put her information in the chat. We'll be happy to get you the access to the link. Many of you were so kind and participated 3 years ago when Governor Carney recognized not only did we have the substance use epidemic with the opioid crisis, but we really had a fractured, broken mental health system, particularly affecting our children and our families. And so our goal over the past 3.5 years together statewide has been to put forth this action plan that was based upon real talk across the state, identifying needs according to the 6 major categories, which you can read about. I'm not going to go over those here, but they range from data and policy to access and treatment to education, family services, and a lot around social determinants. So what we can do for children. I know when I'm out in the community, it's really the children that get my attention first. For those of you who I'm preaching to the choir this evening, they know full well who I'm talking about. The children who are couch surfers, whose families struggle with substance use, who during COVID perhaps have experienced eviction, more domestic violence, and yes, that horrific crime of childhood sex trafficking. And I know in Sussex County, we have a whole bunch of women and men coming together, opening one of Delaware's first placements for children who have unfortunately experienced sex trafficking and trauma. And thanks to many of you, when I was in the Senate, we were able to lobby hard and get Sun Behavioral Health to come and agree to have bids for inpatient treatment for our young adults, young children, 12 and up. But as Rosie said, we got a lot of work to do as far as the staffing shortages in our state. I know Dr. Marlene Saunders, I want to say thank you to you and the incredible team here and all of the amazing sorority sponsors, our Southern Alliance, who recognizes why we need a consortium with a plan. There is 117 action items out of 1,174 goals. We've accomplished over 80% of those. And a lot of it is breaking down silos, putting together the fractured systems between youth and family services, problems with transition to adulthood, issues with social determinants and housing. And as Norwood said tonight, helping people understand the feeling language. And as Rosie and last week with Gail and Erica and Natasha, really letting children and families know it's okay not to be okay. It is all right. And that we have to come together through systems perspective and make change. An area that I have to mention, one of the things that I thoroughly enjoyed more, and I know this came out last week, and I don't want to jump ahead to my question and answer time, but has been my Board of Pardons work. the one common denominator, and I hope everybody wakes up for this part, the common denominator, particularly when I'm looking at commutations, which are persons who've been incarcerated, who've gone before parole, who come before the pardons board looking for a second chance. The common denominator, and I would say 99%, have been in their juvenile years, some form of mental health, substance use that has gone untreated. That is such a common thread. And I know thanks to many of you on this call, you live it, you breathe it, and you try to address it with the ACEs, the trauma, and other levels of care. Our governor, the Family Service Cabinet Council, our First Lady, Tracy Quillen, really working hard to address trauma. Thank you all for that. So, as Janae's probably waving to me on my team, talked enough. I'll stop so that we can get to some questions and answers. But I do just want to say thank you, and to use those resources to share the best ideas that you have. You know, we have put in place in Spanish and English and Haitian Creole our Hope line, you know, the 8339 Hope DE that folks can turn to for services, the 211. But we all know it doesn't do any good if you call that number and there's no one who can come. So early on in your slides, thank you to Dr. Saunders for putting up the mobile crisis phone, to making sure people know who to turn to. And it's really, you know, okay not to be okay. The good news is, I'll end on a positive, like Norwood indicated, I want to share that the Lieutenant Governor's Challenge, which focuses on mental and behavioral health, a special program that we offer, that we're wrapping out this year's applications. Our first winner was at Family Life Center there at Eisenberg School and Colonial School District. So to you, Norwood, and your team, you know, thank you for looking at the positives around mental health and mental wellness. In addition to, as Dr. Saunders typed in the chat, you know, thank you for avoiding just talking about pathology, but wellness. And that's where it matters with our children and prevention. So final thing, really focused on also early childhood. My office is spending a tremendous amount of time with the Hunt Institute and the Department of Ed. Tonight, we could spend hours talking about House bills and General Assembly. House Bill 100, Representative Longhurst is sponsoring more mental health in our schools, you name it. So I'm game. I've got my sleeves ready to roll up, answer questions, and I'll go back to my classmate, Ms. Clark.
Thank you, Lieutenant Governor Hallgong. Your passion for helping every child in Delaware always shines through, and we do appreciate that.
Thank you, thank you. And actually, while I was talking, Dr. Gibney called me, who's my colleague and companion on the street. You'll see us out all the time, so I'm sure she's calling wanting something. So that's what it's about. We go together, right?
All right, that's right. Yep. Teamwork, right? Next is Gail Quinville. She started her career as a special education teacher with students labeled SEI, severely emotionally impaired, in the early 1970s, and learned the severe damage that label was doing for their learning. She has been involved with Head Start in Detroit in 1978, and most recently in 2016 in Sussex County. She has worked with children and adolescents and their families, co-founded therapeutic preschool, consulted in the school systems, and facilitated parent groups. Thank you so much for joining us again this week on our second mental health webinar. Welcome. You're muted.
Sorry about that. Thank you for having me. I'm very flattered, delighted to be a part of this discussion, and certainly resonated with April, who sees the full array of what comes into schools, and with Norwood, who talked about the language we use to help people just put their feelings into words, even delineating the difference between being sorrowful about something and then getting the label of being depressed. And even with what Rosie said about the need for bilingual therapists, because I know that people talk about their emotions in their mother tongue basically easiest. So I'll talk a little bit about my first work with kids and why I carry what I learned from them with me through life, and then a few things that I've done, and we'll leave it at that unless there are questions at the end. I started my career with the SEI, severely emotionally impaired adolescent, 6'2", 250 pound, in a very inner city, poverty-stricken area of Michigan. And to say they were enraged is putting it mildly. One kid would come in every day and throw all the chairs in the middle of the room, and then I'd say them by name and say, well, you can take those down because my job is to teach you to read. But what I learned is that the label really belied what was going on underneath. If I had been living with any of the stressors they had, I would be angry too. And what I learned is that just because it was more common for them didn't make them any less afraid, scared, fearful, doubtful, untrusting. Much like we liken divorce today because it's more common, it's not easier for kids. Because it was more common for them, it wasn't easier for any one of them. And that has carried me through life, because I ended up not treating them as if they were severely emotionally impaired, but had stressors. And when you come to school, any stressor impacts you, whether it be great or minor. And this capacity to reach people who are so stressed, living in poverty, living with abuse, living with neglect, living as if they were disposable in this little portable, I was stuck out in the middle of nowhere with them and no resources and help, really taught me a lot about stressful situations that children and their families go through. So I thought I'd talk about some of the programming I did and that I've been involved with after becoming a therapist. I consulted in schools and preschools, initially pro bono, and then eventually they paid me. And we learned through these consultations that we needed our own therapeutic preschool. So I was part of a group of therapists who co-founded or founded the 4th therapeutic preschool in the country. And every parent got a consultant. So someone like me who would just help them navigate the schools, their entire family, not just the child who was in the preschool, and could be kind of a coach and resource for them. And that was an incredible program. It really taught me the value of supporting families in what we used to call wraparound, but really supporting families. The other thing I did was I ran a parent group that was all males, any male who was in any parenting role at all, be they a grandparent, an uncle, foster parent, someone, a step parent, a biological parent, in any way that they were in a parenting capacity. And I was really happy to hear, I think it was April or Nora, I'm sorry, I think it was April who talked about helping families be comfortable in the school setting. These men were very reluctant to come to the school for a support group. And as we garnered more participation, I remember one evening the principal came and the men said, "We're not going to hurt Miss Gale. What are you doing here?" He said, "I'm here as a parent." And it really helped these men feel much more comfortable just entering the school building to have that principal be a participant in the group. And it was a phenomenal experience to see these men learn to feel love and support for each other and then for their children. Another thing I've done is I'm a trained divorce mediator, whatever that means. I have a little certification for it. So when we were doing consultations, we consulted with the family courts as well. And in Michigan, it's almost mandated to go through mediation before to courts. So every family that's going through divorce gets a mediator to help them with their children with that. One of the things I've had a lot of success doing is treatment via the parent. So when I get a phone call that a child needs treatment, I will first work with the parents, and not that they are therapists, but they're therapeutic with their kids. And I help them actually change their relationships and how they talk with their children and when to be able to talk about feelings, how to read expressions behaviorally that are really of internal feelings and emotions. And that's been actually quite effective as well. The problem with diagnosis is it both helps and hinders. It's not one or the other. But one of the things I've been seeing more frequently in the last 2 years is kids as young as 3 years of age getting a diagnosis of bipolar disorder. So this is where the diagnosis really hinders, because I may have looked bipolar at the age of 3, I don't know. Many 3-year-olds act out their feelings and they can appear to be that way. And then that child can carry that diagnosis all the way through life. On the flip side, it's very helpful to know if a teen is having an actual psychotic break and going into a psychosis. And so I think we need to understand how labels or diagnoses help and how they hinder, and be careful of how we misuse or use them. So I think that's about all I have to say for today. I could talk a lot more, but that's pretty much what I wanted to share with you today. And I likewise am open to any questions at all. So thank you very much.
Thank you, panelists. All of you have brought a different perspective to this conversation, and I thank you all for your different levels of expertise and your lens for this discussion regarding mental health, wellness, resilience with our children. I want to encourage those in the audience to feel free to add questions to the Q&A. We'd love to have a chance to have some more dialogue with our panelists. And we do have a couple of questions already queued up, so I'm going to bring those forward. First, the question says, how are parents made aware of the resources offered in the school district? And this may be directed to Ms. April Harmon, and others can chime in appropriately.
Yes, I can answer that question. Typically, in my role, I make it a point when we have our in a traditional setting, pre-COVID, when we would have our open houses and back to school events, I would always have a table to advertise our programming and offering services to students, because one of the other things that I coordinate in our school is our food bank backpack program. So that's an opportunity for me to kind of assess and see what families are in need of food, and to sign them up and to tell again about our services. I'm often surprised to hear from parents that they are unaware that the service is there. Oftentimes too, they are asking questions of whether or not there's a cost associated with the services. So they're very happy to hear that, you know, our program exists. And then on top of that, there's no associated cost. And the close list that we work with the families makes them, again, open to the idea of allowing someone like myself or my fellow FCT colleagues to work with them. So that's one of the ways. And often word of mouth. I have families that have shared with others in the community about our services. I've also have like families who might have had a child early on. Again, this is my 11th year, so I've been around long enough to start to work with siblings at times, because again, that relationship has been built and they feel comfortable seeking me, even if it's not to open a case, but to ask questions or receive directions on, you know, what avenue they should take regarding certain concerns that they may have, whether it's mental health related, whether it's regarding resources for things related to their housing. So they always know that they can come to me in our school.
Thank you, April. Another question that's from one of our attendees says, if a grandparent is concerned for a grandchild's mental state, how can the grandparent assist with getting the grandchild help within the school district? The grandchild lives with the mother. And I'll leave that open to whomever would like to to start?
I don't mind taking that. So my understanding of the question, Deborah, is that the child lives with the mother, but the grandparent is concerned that the child needs help, but they don't have guardianship or anything of the child, correct?
That's what appears. The child lives with the mother. They put that in parentheses, so I
Yeah.
think they're looking on as the
So
grandparent.
in that instance, I mean, of course, it would be difficult for the grandmother to expedite things because of not having the guardianship and things of that child. However, it's always a good idea to reach out to the school maybe and find out services available to share with mom, because that's kind of like a loaded question as far as, is the mom also concerned? Does the mom need support? Does the mom not know who to ask or who to reach out to? Because again, the school setting can be very intimidating, and oftentimes families don't come into the schools unless they are scheduled for a meeting or need to be there for some reason. So I would start off by finding out whether or not the mother is aware that there's concerns, that she too have concerns, and if so, to reach out to the guidance counselor first. And the guidance counselor should be able to direct that family into, other services that are available. Like in our school building, it's myself as the family crisis therapist, and we have recently been so lucky to have a behavioral health consultant who's been with us, I believe, for about 2 years now. And then, of course, our guidance counseling team, we do have 2 guidance counselors. So most schools have a guidance team, might have a social worker, might have an FCT, and could have a behavioral health person in their building, and also outpatient services that are being brought into the school.
Can I chime in also?
Yes,
I think, thank you, April. That was really, really good. And one of the things, as I think about some of the resources in the school, I think I always consider maximizing the resources in the school. Schools are, for many communities, the central place where families actually meet with their children. And there's so many resources just in the school building itself. And I was thinking about what Gail had shared about sort of this. Uh, there's a negative stigma to mental illness or mental health diagnosis, but they're all because people, for whatever reason, but there's often a tremendous gathering around of people when there is a concern, when it is attached to a physical concern. One of the things I think about is that the school nurse who cares for every single person in the building is one of the most tremendous resources, but often the school nurse is only thought of as the person who puts on Band-Aids or gives, a Tylenol when someone is ill. But the school nurse knows every single child in the school. The school nurse has a very powerful and rich relationship with every person in the building, as well as every parent, as well as every, grandparent. And there's a different level of relationship. And so I think about how, the school nurse can often, not that you want to go to the school nurse, for all issues, but I think that, when we consider all the villagers in the village of the school, that also considering how the school nurse, if the child, for example, what we know is that mental illness and physical illness are interlinked because we have a body brain. And often that connection of, well, there's a concern here for the child's behavior, which is an activity, and that has some, may have some emotional things going on beneath of it. And we want to take a look at, are there other capacity, other things going on? Are there some physical things, particular, I think Dale talked about children cannot speak what they're experiencing well, but they also can feel it and they experience it through their bodies. And one of the ways that, we see the kid that's picking their fingernails, we see the kid that's doing all kinds of behavioral things. And what we see is the behavior, and we haven't asked the nurse, is there a meaning for this? And sometimes that conversation can be a wonderful bridge for families moving into the conversation of some deeper feelings. So I think that can, and nurses are really wonderful with saying, hey, this is not my I see some other things going on. Let me make a referral. And that can also be a wonderful way for a grandparent or any family member to be able to say, hey, we just want to wrap around this child, because it's really about all the villagers coming and wrapping around the child. So I want to keep that, I wanted to add that nurse piece in there.
Great.
And I would jump in and say that while it may not have a dramatic change, that grandmother should feel comfortable going for a consultation. It doesn't necessarily have to be therapy, but my pet phrase for people who are resistant to get help is, you don't need to struggle alone with what you're struggling with. So helping that grandmother see that she does not have to sit by and be passive and struggle with this alone, getting a consultation and seeing if there isn't a way. We obviously don't know the dynamics between the mother of the child and the grandmother, whether it's her daughter or daughter-in-law or whatever, but to help the grandmother get some skills to time when she can move in and say to the mother, you know, we don't have to struggle with this alone. There's help out there.
Great, thank you all. I have a couple other questions are coming in. Keep them coming, our attendees. I appreciate that. Focusing on wellness requires a special kind of mental health professional, one who can use professional relationships, is empathetic, is culturally competent. Such individuals require special training. There is only one social work program in Delaware that does not have resources to attract top faculty and students. Ms. Rossi addressed the need for the workforce. What is Delaware doing to bring in substantial social work workforce that can promote mental health, wellness in children? That's a mouthful, but I can repeat anything you need.
I'll get it started and they can follow up. They are in the trenches as social workers, counselors, et cetera. And myself teaching the future workforce in public health and actually having graduate students both in the master's and doctoral programs, psych nurse practitioners. At the end of the day, it comes together, and Sussex is tonight, I know, major focus. So here we have health profession shortage area, but statewide, as Ms. Rossi indicated, the data that she shared earlier, we've got a lot to do and more work in hand. And so I think whether it's our social work program that was just referenced, in the dialogue with Del State, whether we were looking at bringing in more licensed social workers, we have a lot to do and not just talk the talk, but walk the walk. And that's why part of our behavioral health consortium under our data and policy section, that's a very clear cut recommendations working with members of the legislature. So again, some of you are a little more politically active than others, those who can be. As you join your associations, you're part of the sororities, you're part of the Southern Alliance, whichever organization you're with this evening, you're playing a role and helping us to ensure that we have the workforce. House Bill 111 is an example for the schools right now with Representative Longhurst and others bringing in employees. The challenge is, will they come? We have to make sure we have the competitive environment, not only the beaches in Sussex, but other reasons that people would want to come here. And so we have to make sure to have a level playing field, competitive benefits, but really, the experts here can share with you some of the ups and downs and hurdles and challenges that they face. I know I'm ready to put my shoulder in to the pedal, to the pads, to try to do everything that I can with you all collectively to grow the workforce, because we have such an incredible demand, and particularly post-COVID, even with telehealth, which, again, was a whole nother story, a whole nother journey that took us to get that passed. It's certainly not enough, particularly with children. So I'll quit talking and let one of my other colleagues who has probably some really great ideas that we could probably hear from them.
I'll just add to what Lieutenant Governor said, which is a focus. We need a focus. We need to have a targeted recruitment strategy. We need to develop upstream outreach and recruitment that engages diverse talent. We need to enhance the client experience. I have 7 slides on this, and it is what we talk about every single day with our partners. We're working closely with Del State because it's a leading organization in the state and want to be able to support that. We're working outside of the state with Bryn Mawr, the social work and many of you know that program. We're looking at being able to take talent that is retiring in Delaware and utilizing that talent on a part-time basis. We know that Sussex is the fastest growing county. And where are those people coming from? They're coming from Pennsylvania, Maryland, New Jersey, throughout the country. We need to make getting them licensed and active easy. Getting licensed isn't easy. And especially when you're retiring, the last thing you want to do is something that's hard. That's why my hair is grayer. It's really a collective effort to look at everyone and all resources. There is even an idea of using peers. Peer support is so instrumental and so critical. There might be a level of support that's available for our children that is not children to children, but people who've experienced some of the same trauma and challenges can work with those children at a peer level, supervised by a licensed clinical social worker or psychologist. So we must think outside the box to be able to maintain the growing demand for services for children.
Any other reactions or responses, panel? Gail?
Yeah, you can't have too many programs when it comes to kids. I'm sorry. It's like a school teacher. You can always present something better. You can always do something more creatively. You can always come up with more ideas of how to teach. But with kids, we have an opportunity actually to do a little bit of leveling of the playing field if we can reach out to each and every child in some creative way that makes a difference, and to each and every family that matters. And these are going to be policy decisions, what is it, 2035, there'll be more of us over 65, then there will be children. So are we going to put financial resources based on population or by need? I'm not saying over 65s are disposable because I'm there, but I'm saying that these are policy decisions we're going to have to make. And I think when we work with children, it's a real merging of clinical and management, right? Like when we see someone who's actively suicidal, we have to be clinically sharp and we have to manage that. And that working with children brings that bridge. So when we approach work with children, whether it's the school system, whether it's a private practice office, whether it's a clinic or organization, we all have to wrap our arms around these kids and think both ways and not lean toward one or the other. And I think that's the creative challenge for someone like Lieutenant Governor in her programming, to really think, okay, does this address just this need, or is it going to address more than one need? And how do we get there? How do we push that boulder up the hill and get there? So
Yeah, I was gonna, thanks, Gail, because I was thinking along the same lines. One thing I thought about and listening to the question was that the question talked about wellness. And I always keep in mind that wellness is not a specialty that a person goes to school for necessarily. Often wellness is something that we innately have, and then life sort of chips away at it for many people. And so, but one of the things I was thinking about, you mentioned the peer specialists and that sort of thing, and those kinds of supports, those sort of community supports. And one of the things that Gail had mentioned was that they had, I forget what you called it in the school, but you had a parent with a consultant that connected directly with the parents, where the parents were learning not necessarily therapy, but they were learning how to really enhance their therapeutic wealth and relationship. And when you there was a program that I'm playing with and still thinking about, but it's called grandmother benches, where they set benches and they taught local grandmother or local people to some of the basic skills that are incorporated into wellness, and they would just be in the community there to serve maybe perhaps a parent that may be struggling with a child. And there's for many people a cultural connection with that relationship. But so all kinds of wonderful creative things have been done. All kinds of wonderful creative things can be done. And when I think about what Rosie had shared about with attitudes and how we begin to move beyond the attitude of that mental health and mental illness are the same thing, in that, and wellness is only, and mental health is only a piece of overall wellness. People live with mental illness for entire lives. Like, people live with physical illness for entire lives. It does not mean that they do not have wellness. And we want to begin to move our attitude away from, as Gail talked about, with diagnosis as being some sort of mark or label or scarlet letter. Diagnosis is useful for a physician. It's useful for me. Underdiagnosis shuts the door. Overdiagnosis locks it, but accurate diagnosis helps the doctor do things. But then we have the conversation, the human conversation with the community to say, hey, this is how we talk about it. And so I want to just add that was a really inspiring question for me. Thanks.
Great.
A
Well,
great question. I know you want to get to the next one. 30 seconds. I can't believe I forgot this. Many of
No,
you
go
know
ahead.
the community health worker model. It's been something the Behavioral Health Consortium has funded. It's terrific. It's an opportunity. It's one more cog in the wheel. Goes along kind of what Rosie was saying, a little bit of a different level, peer education, but the community health worker also. And a lot of them have been funded through the Behavioral Health Consortium to begin work, and whether it's through our federally qualified centers, private practices. I don't know, I forgot to mention them. We had our summit last week. So we are starting in that direction in Delaware for the first time. We are part of a national organization. If you don't know about it, we'll get you the information about the community health worker organization that has started finally in Delaware. So one more cog in the wheel.
Wonderful. Thank you. I just wanted to bring up this next question only because we're talking about policy and funding. So the attendee wrote, wellness centers are extremely valuable. However, my personal experience is that funding is cut every year. Is there a policy reform plan that will improve sustainability in the current centers as we consider opening up additional centers in elementary schools?
Was that funding cut through the schools, did you say, or through the state? I couldn't hear which.
They only mentioned that their personal experience indicates that funding is cut every year. So I'm not sure if it's from the school district or if it's state funding. That's not clear in the question.
We try not to. I know we went through a dark period 10 years ago when I was in the Senate where we did cut a lot of programs, and then we did cut. Hopefully we'll see a turnaround, and with the emphasis and the understanding, particularly with COVID. One of the silver linings from COVID has been, the shining the light not only on the inequities in community, but also the behavioral health challenges. So, and again, we all know, talk to the school nurses, the public health nurses, and the others. Some people can take that dime and do 100 things, and others. So I would need a little more specificity. And if that person wants to email my office or Janae later and give me some details, and we could look under the curtain, look under the cushion, so to say, to see where that specifically lies, if it's in the state or maybe it's not. I don't know.
Okay, thank you. I do want to say, in response to you all as panelists mentioned about the resources. Several people have chimed in that the school nurses, yes, are tremendous, capital letters, exclamation points. And a couple of others mentioned about school secretaries also being a great resource because they are seeing a lot of kids. Another question was, can panelists identify characteristics of children who get over the odds despite mental health issues or risk factors? So can you give an example or speak to how children get over those odds?
So I can talk about in the clinician's office as well as in the classroom, and I'm going to disguise what I'm going to talk about. So someone who came to see me who was cutting herself, 16 years old, held back in school, literally both parents in and out of prison, deprived nutritionally, lots of problems on medication, in and out of hospitals. Just graduated this year. Probably a year older than she should have been because she had been held back, and she's got a scholarship to college. How did that happen? She just clicked with me. She just clicked. That's all I can say. I don't think I had any magic wand. She just clicked, and I supported her strengths. She's bright. She's smart. She doesn't have to live in her adversity and strife. She just constantly promoting her value and various ways and helping her understand that her parents were limited. It's not that they don't love her. It would be like asking someone without legs to walk to ask them to be different. It wasn't because she was defective. It's because they were limited. So that's a small clinical vantage point. We can teach resiliency in preschool. When some other panelists may have heard this from me. When the kid comes to school and is crying and mommy, mommy, don't leave me, the preschool teacher who distracts that kid with puzzles is doing that kid a disservice. The preschool teacher who says, you can miss your mommy and have fun at school, just taught that kid to have two feelings at the same time, and self-comfort. Self-comfort we teach kids by, you're just upset, it will pass. Resiliency and self-comfort, okay? As opposed to, oh, what are you upset about? You're so upset. Oh, let me kiss your boo-boo, you know, whatever. No, you're just upset. You can't engage with life without being upset. You know, I'll just tell you one more. Someone came to me and said they want to be in a relationship that they don't want to fight. They don't want to be rejected. They don't want to have any problems. And I said, well, then you're not ready to be in a relationship because you will fight. You will have problems. You will get feedback, you know. So it's helping people get ready to deal with the difficulties that life offers, pretty much what other panelists have said. So, oh, and by the way, in Michigan, we started a preschool as an experiment in which it was attached to a nursing home or retirement center. So every preschooler was assigned a grandparent and every grandparent was assigned a preschooler. What a dramatic change at both ends of that continuum. So.
I just wanted to add, if I could piggyback off of what Gail was saying about just things clicking. I think oftentimes when you are working with a child, and I know I found in my experience working with the elementary kids especially, I tend to get referred a lot of males, young boys who display pretty extreme behaviors, you know, profanity, just they want to be seen, they want to be heard, but they just don't know how to go about it in the right way. They're going through an age where they're trying to fit in. And I have one student in particular that I think of often where looking at him, very intimidating, you know, very off-putting, very difficult to reach by some staff. But I feel like I was able to reach him because I tapped into his strengths. And in his case, he was very intelligent, capable of getting honor roll every quarter. So that was the thing that I held on to. So every day when I see him, I could call his name, come with me, just come to my office, let's sit down, calm down, let's talk, what's going on, you know, reminding him of his responsibilities. And every time the marking period changed, let's see what the report card is going to look like. I can't wait to go to the honor roll, you know, assembly so that I can, you know, cheer you on. I know you can do it. This is what we would do to the side, but his peers had no clue that he was pulling this off every quarter. And I kept telling him, when someone looks up your name, they're going to see those discipline reports, but you got to start showing them what you can do in the classroom. So disciplinary record, not very, you know, impressing. However, every quarter, if they look at his academics, straight A's, straight A's. So that's what I tapped into. And I think that helped build his esteem. He looked forward to me coming and supporting him. And I just hung out and stayed with him that whole time. And that was my primary focus with him, is encouraging him and letting him know just how intelligent he is and how much he can do once he leaves the elementary school to go to the middle school, and just reminding him this is his strength. A lot of children struggle with reading and writing. That was not a struggle for him, but he had other, you know, challenges that were outside of school, you know, that I tried to help him overcome and oversee. So definitely building that connection and, you know, having that relationship with that child is very important.
Wonderful. I have a question that's been waiting in the queue for a minute. So let me ask this one. How are children with autism assisted with mental health care?
Well, I used to be an autism coordinator for a year when I didn't want to be in the school district, just needed a warm body to meet their legal requirements. And It certainly depends on how profoundly the family and child is impacted by autism. I don't know. I probably would have to think a little bit where mental health services or behavioral health, whatever we want to call it, had done harm. I can think of a couple of times, but it's support for the family, and it's certainly, again, depending on how verbal the child is. Like right now, I'm working with someone who's 27, diagnosed as Asperger, and I'm realizing he used his diagnosis to avoid life. And so we're turning that around. So he's accessible enough to do that. How damaged is the executive functioning in that child? You know, there are too many variables to say specifically, but it shouldn't be ruled out because of the label. Absolutely. I don't think anyone would think that.
Absolutely. I think one of the things I think about, because I can't answer that question specifically, but I think about it more broadly. One of the things that it popped into my head, because people come to me, oh, you're a therapist, help me with this. And one of the things I think that is so important, and this is why it's, for me, I'm very excited about always being able to share about how to have the conversation about health and wellness, is that it's okay to, first of all, therapists, like doctors, like nurses, like other professions, are specialists when it comes down to treatment. And it's okay to ask. I think it's really important for just for the the consumer, the person who's seeking services for a family member, to ask, hey, to the therapist, what is your expertise? What is your experience in working with with a child that experiences or lives with on the autistic spectrum, as well as maybe exhibiting or experiencing some other types of mental illness. I think it's a really important question to ask, not simply of this panel, but to ask of the provider that is standing in front of you. As Gail pointed out, you can run into a provider that has every good intention of providing really good services, but their experience, we don't learn, and I have not learned how to be a good therapist in any classroom. I've learned how to be a good therapist in doing the work and building the relationships and doing my extended study and sitting in front of clients. Clients teach me how to be their best therapist. I don't teach them how to be their best them. And so for a client to come and ask me, for one, is a really big honor to say, hey, what is your specialty? Because I'll tell them, this is not my specialty. This is what I really have great experience and work with. And I think it's an empowering question for a person in the community to be able to feel comfortable going to a therapist or a doctor or any professional and saying, hey, is this your specialty?
Great, thank you.
And
Go ahead, Rosie.
and there are trained therapists who have ABA, which is somebody here would have to tell me what that is, but that's a very specialized training for individuals on the autism spectrum. And we're training more and more therapists to be able to deliver that service, which is good. But as we continue to train, the cases of autism goes up. So we're not training fast enough.
Did you say ABA, Rosie?
Applied
Behavioral analysis. So the
Thank
new
you.
trend right now in autism is a lot of parents are rejecting that. I can tell you offline what's going on with that.
Okay.
But I worked with ABA. It has its positives and its negatives. And again, just like any diagnosis, any one methodology is not going to solve all the problems that people struggle with. And the one thing I would say is that it's going back to what I said originally, any stressor that a child walks through the door with impedes their capacity to relate, learn, process what's happening, grow. Whether it be their parents had a fight that morning, whether it be they didn't get breakfast or there isn't enough food, whether they're worried about their ADHD brother, whether they're fearful of someone in the neighborhood, all the way up to severe traumas. So anything impacts their capacity to learn. And that's where it really does take a community to raise kids. And school systems really should be more of community centers for those families. So.
I was going to add real quick for the autism spectrum disorders. We actually have lots of General Assembly through many years of worked hard to try to provide additional coverage and insurance and programs in the schools and resources, and even through the University of Delaware and others for those who are on the higher end of higher functionality. You know, we have special programs. So a success story. I have a good friend whose child was Asperger's, who at the time was told, oh, they'll probably be in facilities management. That child is now making a 6-digit figure doing computer programming. And so again, that's high functioning autism, Asperger's. So there is hope, and not everyone, comes from lots of resources, but we have those in Delaware. And thanks to the networks that are formed tonight, we can try to uplift those kids. So again, like you said, not come away with just the negative, but as I'm inspired by listening to these panelists tonight, you all inspire me to keep doing the good work.
This morning I was at the Hope Center and I was inspired by being in the parking lot because it's a place, it's a center, it's a resource. I want a Hope Center in Sussex County. If there isn't already a plan for one, I'd love to help make that happen, because there we have organizations, individuals, agencies, wrap around everything to help families meet their basic needs.
Right.
And as that program continues to grow, the idea of having one family have one family support them, one child have one friend that they can have and give them that confidence. To me, that's just an example of what our state can do, because we're small, because we're connected, because we know each other, because we're players, because we want solutions and we want everyone to be healthy in every way. So I think that Marlene is absolutely right. It's the macro issues. It's food, clothing, shelter. It starts there. And until we have that, some of these things, it's reducing gun violence, it's equity, it's inclusion, it's all of the above. And until we get some of that under control, it's the layers.
I have to agree. It's multifaceted, and I think that work has to be done on a lot of fronts kind of simultaneously, and there's lots of competing needs and compelling needs, and we have to figure out how we're going to navigate those things. I do want to try to get to a couple of more questions that were posted because we are coming short of time. We had one person who had moved from DC here, was unable to get their son in public school, had their child enrolled in a private school. And their sentiment is, I feel like we need some services, but the private school missed the boat. So I think, again, it goes back to several things that you all have talked about, that there's sometimes gaps in what's available in meeting some of the needs to students. I don't know if any of you have experience with some of the private schools that you want to just chime in quickly, but compared to what's available in the public schools.
Yeah, I think if I heard the question well, is that the person placed their child was placed in a private school, and one of the private schools can be limited in that they're public schools have a different level of responsibility for, particularly if a child has a health concern, whether it be a mental health disorder or a medical disorder, just based on the law that a private school is a private entity, and so they operate differently, whereas a public entity, like a public school, has to operate within specifically within the lay of the land, where and so there can be some complications. I'm sorry to hear that happened, because that sounds very painful to raise a child. I know that people make decisions in that way. They're not easy decisions to say, I'm going to place my child here, place my child there. I think that one of the things I think about is that a child's educational experience does not, while there could have been some injury and some wound there, it does not direct their life experience. And I think that, one of the things that can be useful sometimes is, processing even that injury, because that can be traumatic, to have that experience of having a child placed in that kind of environment. I think I would like to. I think it would be helpful to know more, but I don't know that we have the time for that. But I wanted to hear also what I saw the Lieutenant Governor really excited to to give some response. I wanted to.
I can respond, but I think April goes ahead of me because y'all are in the trenches. I'm up there going, go April, go.
No, I was just going to add, and Lieutenant Governor, you may be wanting to share more resources as well to this, but I was just going to say, like Norwood said, I don't know the detail of the situation, but if it has to do with anything academic related in regards to like learning concerns, or even if it is mental health related, pick Parent Information Center is a good resource to reach out to. Pick of Delaware, I believe .org, or you can just Google, but they are a very good resource to use for the parent to kind of navigate and get assistance on how to take on something in the private sector, or be able to know, what moves to make next. But they are a very good resource to use. So that's Parent Information Center.
Good job. That is great to include. And then certainly depending on the services, we know in the northern portion of the state, a number of individuals turn to AI DuPont and Moores, and then certainly, and our federally qualified health center partnerships, whether RAD and some others provide some linkages with integrated care, not quite to the same level that they should. And it's a really true factor. One of the hard components in Delaware is we have 19 school districts for a small state, and then we have the private schools. It's a lot of information. And so that's why I think having these conversations, working with the school nurses, working with the partners, really important. Not only Department of Ed, but our Department of Youth and Family Services, Youth and Prevention Behavioral Program. I know for myself, my son, having had an IEP 504, we have it in public school, private, he had to go to charter school, and then I ended up in a private school for him but I had to pay extra for a very, 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 very focused program because he had reading, writing, math problem. But I had to do a lot of homework. It was not something I had envisioned. As a member of the public, I had always wanted public education, but for him, it was actually prescribed through the behavioral health unit at AI DuPont and Moores. And so it's a challenge. And getting that right need and those right programs and the right diagnoses, as Gail stated, when kids are labeled, it's so important that we get it right. And that's one of the reasons, I'm so incredibly passionate, not only because I'm a mom and a nurse, but, I've lived the walk with many of you with family. And, I'm so thrilled that in Sussex tonight, you brought us together. And I know our time's ending. And I do want to say two quick things, if you don't mind. The JED Foundation and Amy Kennedy and Patrick Kennedy. Patrick Kennedy, as you've heard me say before, mask your emotions, mask COVID, not your emotions. We've been doing campaigns with them, and I'll let you all know, I anticipate having them visit Delaware. They're going to be here with us sometime in July. And Amy Kennedy has made her life's work about youth and childhood suicide prevention. So I know that's a piece that we didn't focus a lot on tonight, but we certainly know that has been a real issue this year with COVID, with the suicide piece. So if I didn't say it, my office with Janae will certainly let you know when we have those guests here visiting us in July. So that's all I needed.
Well, thank you all. I think we've nearly gotten to most, if not all, of the questions. I thank you all for submitting your questions to our panel, and hopefully that you found their responses very informative. I think there's a lot that we identified that are helpful, useful services in Sussex County, but also additional places where we can see some need. And it's a work in progress. And I want to really thank you, Lieutenant Governor, for your part. So I'm going to turn this over to Jackie Wade, who will close us out for this evening.
Thank you, Debbie. Thank you, panelists, for an incredible evening. We thank our sponsors and the Event Planning Committee for bringing this important topic forward. Most importantly, we thank you all for joining us tonight. And you will find a link in our session, a session evaluation in the chat. So I believe Mr. Jackson has put that in the chat already, and you will receive a follow-up email. So please share your feedback regarding tonight's session. Lastly, we are planning a call to action session. More details will be sent by email soon. So be well and stay safe, and good night.